Good afternoon. We apologize for that technical difficulty. We are just starting the meeting a few minutes late, but we will do our best to make up time and still save time for Q&A at the end. But thank you for joining us. Again, our apologies. I would like to start by introducing Dr. Jim Burdine, and we're just going to kind of skip intros this morning and go straight in to make it for some lost time. So I'm going to go ahead and turn it over to Dr. Burdine. Thanks for joining us, everyone.
Well, welcome. I'm going to figure out how to cut 12 minutes out of the next, an hour-long presentation that probably should have was designed for about 3 hours. So I'm going to talk fast, and I apologize. I'm getting over a cold, so if I start making up obnoxious noises, my apologies. But we don't have the sneeze button here that I can push to silence the microphone. I do have a box of Kleenex, so I'm ready. Thank you, Cassidy, and welcome, everybody. We're here to talk about community health status assessment, or community health needs assessment, and it's a tool that has multiple purposes. So I came up with this corny Swiss Army knife analogy, which Cassidy has been rolling her eyes at, so I'm assuming I should have worked on something more clever. But anyway, it's a tool that has a lot of purposes, and so I want to talk about the tool, but I also want to talk about application and leave as much time as I can for questions and answers, because this is a very personalized kind of process. I've done a couple of hundred community assessments over the last 30 years in every kind of community you can imagine, sponsored by hospitals, philanthropic organizations, private sector organizations, lots of different sponsors and teams, groups of sponsors, and really no two of them have been the same. I mean, there's a core sort of gold standard model that we'll talk through, but basically the assessment needs to reflect the situation of the community that you're working with as a function of resources and other characteristics we're going to talk about. So let me start off with a couple of examples that I use when I'm talking with community groups when we talk about community assessment to discuss some of these ideas. So Cassie, if you want to flip through, this is I'm sorry, you back up one. There we go. Nope, one more, the other way.
Maybe.
Well, we'll just use that the way it is, make it simpler. Story I wanted to talk about is what's called the parable of the blind men and the elephant. It's a tale about a group of blind men who are for some reason walking down a mountain trail, and they come upon something blocking the road. And because it's such a narrow pathway, they can only go up one at a time and try to figure out what this thing is. And the first guy goes up and grabs something, and he comes back and reports to the group, it's like a giant tree in the middle of the road, or in the middle of the pathway. And another guy goes up and he grabs another part of the elephant and comes back and says, no, it's not like a tree, it's like a snake. And the third guy goes up and feels something else, there we go, and comes back and says, no, it's like a wall. Well, the point is each one of them is gathering data from their own unique perspective. And so until we put all these pieces together, I'll go ahead and switch forward. We don't know what the pieces are, so you can go ahead. Thanks. And that's really the point of understanding when we do community health status assessment, it's like assessing health status of an individual. We're going to look at lots of different kinds of data that look at lots of different systems or organs within a larger system, and that's a framework that we can use in understanding what the pieces are. Okay, this is another example I use with community groups to get them to think a little bit differently about outcomes, because we are so programmed to expect and think of certain sorts of solutions as appropriate in different circumstances. That's what this is for. So I'm going to just, again, move through this rather quickly. Imagine that you're a group of folks that have been called together by the state health department, and they've got a report that says infant mortality in your community is much higher than we expect it to be. And so we're concerned about that and wanted you to know. And so we get a group of folks together and start talking about, well, what do we know about infant mortality? And the first thing we know is that there are a couple of primary causes, genetic issues and low birth weight infants. Well, we can't do much about genetics, but we do know that we can do some things about low birth weight. For example, women who don't get adequate prenatal care, who have poor maternal nutrition, or who smoke while they're pregnant have lower birth weight babies, contributing to the risk of infant mortality. All right, so we kind of decompose this or deconstruct this idea and think about the fact that, okay, if lack of prenatal care, when we examine these characteristics, is the thing in our community that seems like it might be driving low birth weight and therefore infant mortality, What is it about the lack of prenatal care? Is it that people don't value health? And I don't mean that in a judgmental way. I mean, if you're, an individual single parent with 2 or 3 kids, working a couple, 3 jobs, going to well baby visits or prenatal care, where, you sit around for 45 minutes waiting for somebody to tell you everything's fine, come back in 2 weeks, that's not a lot of positive reinforcement if you're taking off from work or having to pay for childcare to participate in that. So maybe it's that value of the benefit that they perceive. Maybe it's just the lack of knowledge. They don't know about the value of prenatal care or the risk of low birth weight or infant mortality. Or maybe it's just simple accessibility to where the prenatal care is available. And is that a function of transportation or language? I'm going down. Or cultural values. There are some cultures that have a role, something in many times called a granny midwife or a promotora or other roles, where younger women go to that individual to ask questions about childbirth and all sorts of related issues, maternal child health kinds of issues. And so when we're suggesting that Susie go to prenatal care and not go to that older woman, then we're actually asking her to do something that's a pretty significant cultural deviation, and there are likely to be taboos associated with that. So it may be that that's the issue. In our case, we're going to decide, no, it really is transportation, but we don't know, is the transportation issue a function of not having money because there's no public transportation in your community and you've got to hire somebody, pay a cab or Uber or a neighbor to drive you? Is it the physical location you can't get there? Or is it the fact that some of these women don't read and therefore they don't know about the value of prenatal care or where to get the care and that sort of thing? So the example that I use with community groups is to say, if we started this conversation with, you have a problem with infant mortality in your community, I can guarantee that a literacy program probably isn't something you would come up with as a possible solution for that problem. You'd probably say, well, we need a clinic or a doctor or a nurse midwife or something like that, which are all good solutions. But it may very well be completely off base in terms of what in a particular situation we might want to look at. So again, these are just examples to help us sort of think through and talk about why we look at health status and assessment in a particular way. This is a definition of health that focuses on capacity rather than disease states. It also is a way of helping us to think about some ideas that are broader than some of the traditional medical model-based assumptions that we want to look at. Okay, one of those sets of assumptions are what are called the social determinants of health, and these are characteristics that are part of the physical or social environment, their behavioral and psychological factors related to things like income, employment, housing, education, that all influence health status of individuals and populations. The next slide is a diagram of some of the social determinants of health, and I'm not going to read that to you, but this is an idea that if you're not familiar with, although I presume most of you are, it's worth reviewing because this is a framework that helps us think about how do we want to understand the factors impacting a population's health. It's an old idea. It's been around for at least 20, 25 years. This is an older diagram of the same sort of concepts. This one focuses a little bit more on policy and on access as factors that are related to that. So I'm going to take a breath here. Remember to do that every 10 minutes or so. And just simply point out that there are a couple of reasons why we want to use population health data and why we wanted to use a community health development approach to drive our program, service, and strategic planning kinds of activities. And that's going to make more sense in a minute. But part of the reason is that these factors influence population health status and allow us to allocate resources more effectively and evaluate the results of what we're doing. But also a population or community health focus requires that we engage the community in the process. And that increases the resources that are available and the options that are available for approaching solutions. So community health, thank you. Community health development emphasizes 2 outcomes. One is obviously improving population health status, the fundamental thing we're trying to do. But using a community health development approach focuses us on building community capacity to solve those problems. So if you think about, we could go out and do a health status assessment, but if the way we do that actually contributes to that community's ability to solve that problem or whatever problems come out of that assessment, and more problems over the long haul, that's a huge benefit. That's a twofer or a threefer, depending on how you want to look at it in terms of the benefit to that community. And fortunately, we have the Affordable Care Act, which is driving, which is driving, all of our concerns with why we do community health status assessment. There are hospitals that have been doing health status assessments since at least the early 90s. First one I did was with the Lehigh Valley Health Network, which at that time was Lehigh Valley Hospital in Allentown, Pennsylvania, in 1992. And it was, like I said, one of the first health status assessments sponsored by a hospital in the United States. But it gave us a chance to understand what are the factors in that particular environment that those hospitals could be working with. And I'll talk about that case study a little bit later. But understanding that the 990 provisions and the IRS requirements that you have to meet to maintain your nonprofit status is a great rationale for doing something that was a good idea anyway. And by the way, there are lots of other organizations in your local community, local public health, you have federally qualified health centers, HHS-funded initiatives, area HCNH, and community block grants, many other programs, United Ways, have similar requirements for either education or reporting purposes. So they're doing community assessments, maybe not as comprehensive, maybe not exactly with the same format as what you're going to be doing, but if you're not doing it in collaboration with these organizations, you're missing a huge opportunity. And so I'm going to talk about that a little bit later. Okay, so each one of these assessments, at least if you're following the Affordable Care Act requirements, has two components. They have the health status assessment itself, examining what are the factors that impact the health status of a particular population, but they also include a health improvement plan, which is your plan as an organization to deal with that issue. How are you going to try to solve that problem? What kinds of resources are you committing? So let me go on and clarify a couple of other things. One of the things that I find frustrating, you can go ahead, yeah, thank you, is the way we think about health status and health needs. The community health needs assessment is actually the language that's used in the Affordable Care Act. And unfortunately, there is no unit of measure for need. So when people talk about needs assessment, it's not clear to me what they're exactly trying to measure. When we talk about health status, we know very clearly we can measure functional health status, we can measure disease states, we can measure risk factors very precisely, but need is not something we have much ability to measure except as a perception. And I'm not invalidating that people's perceptions are not important, but if we can translate and think about health status determinants rather than health needs, it's a lot more beneficial in terms of trying to think about what is it we can do to solve that particular problem. Another breath. Okay, so if we think about population health status assessment from that point of view, it's based on a different set of assumptions. Rather than looking at need, sort of a deficit orientation, health status assessment looks at the factors impacting health, it identifies assets that help us define solutions. So we're looking at a solution-oriented rather than deficit or need-oriented problem. For example, my 16-year-old granddaughter needs a new Mustang. That's what her need is right at the moment. The problem she's trying to solve, however, is getting to high school without riding the bus. So perceptions of needs, if you ask people what they are limitless. There will always be more needs. And there's no unit of measure that tells us whether we're making progress or not, other than we have met a need or not based on certain people's perceptions. So this is stuff that takes a lot more time to go through, and I wish we had another hour to do that, but I'm going to keep on moving ahead here. I do want to insert my favorite newest quote. Community leaders know how to make differences happen. They just may not know how to measure them. Academic researchers like myself may know how to measure differences, but you don't know how to make things happen. And I think that's a word for the wise when you're looking for consultants. We'll talk about that later. Okay, we're going to skip ahead to the model. Go ahead and skip to the next 2, 3, 4, 5. Okay, thank you. This is a model that what I had broken down in the slide set, and you can see when you get the PowerPoint. There are different elements that we want to examine when we think about population health. On the left-hand side, if you sort of think of this as an equation, all leading to health status on the right, there are environmental or ecological or contextual factors that are everything from policies at the state and local and national level that influence health status. There are all the social determinants we just briefly talked about, but there are also community characteristics and population characteristics. Things like community history. Why was the place founded? Were there primarily a single major employer that was the dominant force or still is the dominant force in a particular community? Are there other factors about history related to race or other characteristics that you need to take into consideration? And then what are population characteristics you need to understand about a particular environment? And why might an assessment in one place look different than an assessment in another place because of these population or community or other kinds of characteristics? The middle box, we talk about community capacity building, and there's lots of ways we do that. I'm not going to take the time to go more into it, but it's an area of understanding community readiness or community capacity that's an important part of what we need to understand when we're doing our assessment if our goal is, in fact, to try to solve problems that improve population health status. Okay, so now I'm going to even take a sip of water. There are three primary methods we use for understanding population health, and they're categorized into qualitative methods and quantitative methods. Qualitative methods there's two approaches that I recommend and I've used successfully in literally hundreds of places. What are called community discussion groups, which are kind of like a town hall meeting. There's a methodology for doing them that's well established. The reason I recommend community discussion groups is because they get you to really rich data very quickly and very inexpensively, and they miss some of the pitfalls that using methodologies like focus groups, which were really designed for a different purpose, lead you to. You can do community discussion groups with almost no infrastructure background. You don't need to record things. You don't need to videotape. You don't need two-way mirrors. And it gives you very rich information. We'll talk more in just a second. On the quantitative side, there's data that we get from secondary sources, and we'll talk about some of those in a minute. But oftentimes, if it's possible to do a general population survey, that allows you to collect primary data, new information that's not available from any other source, which can be also, again, really rich when we want to understand what's going on in the community. So let me talk about secondary data first. You can go ahead. Thank you. This is information that comes from existing sources. That's why it's called secondary data. Somebody else collected it like census data for another purpose, to know how many representatives we have in Washington. But we're going to use it for our purposes to understand population dynamics and characteristics. So there's data on all kinds of key indicators that are out there established, things like the Healthy People 2010 or 2020. There are economic, political, social, and cultural information that's available. And we want to be able to make comparisons to look at what's different in a particular environment, a zip code or a county or a cluster of counties, a service market area, a state, depending on how you're structured as an organization, that allow us to look at diseases and other kinds of risk factors. Here's some examples of secondary data sources that you might be familiar with. On the left-hand side is the County Health Rankings website. Go in there, enter your county name, push a button, and you've got a report essentially generated that tells you about the health status on a variety of well-validated, well-established measures. It also gives you the relative rank of your county within your state based on those different kinds of measures. A very useful tool. It's sponsored by the Robert Wood Johnson Foundation, and there are some hospitals and other organizations that simply do what I just described, submit that to the IRS, and at least historically have been able to call that their community health assessment. It's a step in the right direction, but there's certainly more you might want to add to that. The other examples on the right-hand side in the bottom of the slide is the Census Bureau. You can go to the American Fact Finder, do the same thing, enter a county name, and generate all the demographic data you might want to understand social determinants of other kinds of factors. There are also some commercial services. I've got Public Insight up there as an example where you can go in and do a lot more detailed analysis. They have what are called interactives, which are essentially sets of pre-programmed analyses that you can go in and pick from. It's like having a statistical consultant in your back pocket or a health services researcher in your back pocket It's more information than you get from County Health Rankings or the Census Bureau because it uses data from those sources, but then it brings in other information. And we pay an annual subscription. I don't know what the numbers are off the top of my head, but there are a number of services like that out there that are coming into the marketplace, and so you may want to look at those as resources. Okay. Community discussion groups. A community discussion group, you use local intermediaries, somebody who's from that community. You can't see me, but I'm an old, bald, white guy. And when I walk into a room, people make assumptions about who I am, also because I've got a doctorate degree and I'm from a big university. And so they're going to make assumptions about who I am, their degree of comfort with sharing information about themselves or their situation that may be very different than if Cassie, who's not an old, bald, white guy, were to walk in the room. I'm pointing at her as if you could see her. Anyway, she's going to be able to relate to different audiences than I can, just based on the human characteristic of we make assumptions about people based on what we see. Fair, unfair, right or wrong, that's irrelevant. When we want to understand what's going on with different groups of people, we need to recognize that there may be people in an environment, these local intermediaries, who can at the very least introduce us and give us entree to these groups. I call it the sort of extending the mantle of legitimacy. If I can get an African-American pastor who's well-known in the community to organize a meeting and invite me in and say, it's okay to talk to Jim, that will go a long way compared with me just sort of putting up flyers and saying, hey, come talk to this consultant or this guy from the university on behalf of our hospital because you may not get anybody to show up. So we do know that there are people who we're not going to hear from for a variety of reasons in the other sources, like a household survey or like the secondary data, because they don't participate in the census or they're not comfortable answering some of these questions or they're just not as much on the grid. So we want to make sure that we think on the basis of age, race, ethnicity, people with different income levels, and other folks who we may not interact with as readily are represented in our community discussion groups. So, real quickly, this is the agenda we use. We ask people to describe your community. That's simply an icebreaker to get people to talk about their place. When we ask the questions that way, it also helps us define what they mean by community, because we may have one perception. I think of, I don't know, a place, Augusta, Georgia, as one of the other case studies we're going to look at, as having certain characteristics, but that's based on my perceptions of having visited there a few dozen times, not somebody who lives there or not somebody who recognizes that, well, there are very different parts of Augusta. And so when you talk about my community, I'm thinking about North Augusta, which is actually across the Savannah River in South Carolina. It's not even in the same state, but it's part of the same community. Okay, then we ask people to tell us about the issues and challenges facing their community. Specifically, we don't ask about health problems because people are going to talk about that anyway. If you start with that, what you end up is hearing about, well, my diabetes or my spleen or my liver, and that really doesn't tell us very much about the community or the population. It tells us about the individuals, which is fine, and that will creep into the conversation. But if we ask about issues and challenges, we're more likely to hear about racism or problem with the schools or income. One of the major employers is just shut down or whatever. And that's information that can be much harder to find and much more valuable in the long run. Then we ask people about local resources, things that could be used to address those issues and challenges. And here's one where my many hospital clients that I had over the years when I had a consulting business were always disappointed when they were near the end of the list of local resources for dealing with these kinds of challenges and problems, because oftentimes people don't think of the local hospital as a place to go except for individual care, not a partner in solving community health problems. Then we ask people, can you give us examples of local collaboration or the history of collaboration? Have you done something in the past? Was there a church that burned down or a flood or a something that people came together, even if they were divided along, religious or racial or other kinds of lines, but they came together to solve that problem, because then you can use this as an example subsequently to talk about how do we solve these problems collaboratively. And lastly, what advice do you have for us? People will tell you very bluntly if you ask them who the key players are, who it's important to have on your side, who will block things if you're not careful, and that's all critical information if you expect to actually have an impact. All right. If possible, conducting a household survey is hugely valuable because it's tremendous information you can only get that way. It's similar information to what you can get from the many states that conduct the CDC's behavioral risk factor survey data. That's some of the information you might be able to get, but there's nothing that surpasses the value of talking directly to a community, even if it's a few hundred people in a large community. If you do the sampling well, you can get really useful information. Over the past 30 years, I've gone through every methodology you can use, from telephone surveys, internet-based surveys. Early days, we did mailed survey booklets where you literally sent people out a 28-page instrument, and they would spend 45 minutes filling it out and sending it back. It was amazing. That's when we could expect response rates of 60%. Now, when people are so burned out on telemarketers, you're thrilled if you can get a 10 or 20% response rate. So go ahead, Cassidy. So some of the topics you might want to be able to look at, not only the demographics of the population at large, but particular groups, things like functional health status. We obviously do want to know what people's chronic conditions and disabilities, their risk factors, their preventive screening participation. Do they have regular provider? What are their challenges to accessing services? What kind of insurance coverage do they have? What's the social capital of the environment they're a part of? That's where these social determinants come back in. Do they use the emergency room for care? How ready are they to make changes? And what are the community issues people perceive? If crime or racism or lack of places to exercise are perceived as community issues, you have a lot more resources to draw on, rather than just the fact that you can say, well, a lot of people are obese in this community, they should be exercising. When you know why they're not, or perhaps part of why they're not, that's really gets you a long way down the road. Okay, we can skip the next one because that's just some details on methodology that we can come back to if people are interested. But okay, so what I want to do is pick one of these case studies and go through it, because if we take all three, that'll use the rest of the time, and I want to make sure we have at least 10 or 15 minutes for Q&A if that's, I'm getting a nod from Cassidy. So that's the way I'm going to approach this, assuming you're all bought in. Gosh, which one? They're all really good. Let's use the Fort Collins one, which is the second case study. So that's like 5 or 6 slides in. I'm going. Sorry. There we go. Okay. Just a quick moment of background. The first couple of case studies. The Lehigh Valley, Eastern Pennsylvania, 7 hospitals in that region. Didn't work together well at all. The local business community was very interested in trying to get them to not spend so much money on billboards about our cardiac care program is better than your cardiac care program. And there was a local philanthropy that was willing to sponsor this assessment. They had huge impact on their community. Second one is an assessment based in Augusta, Georgia, which is fascinating because of the community demographics. And if we have a minute, I'll come back to that. But the third case study, Larimer County is in Fort Collins, Colorado, is in Larimer County. Larimer County has a thing called the Health District of Northern Larimer County, so the northern 2/3 of the county. Health districts in Colorado, like 7 or 8 other states, Texas has them as well, are taxing bodies that can actually levy taxes to support health services. Most of them run hospitals. In the case of the Northern Larimer County Health District, they leased a hospital to a management firm and got paid a couple $1 million a year for that service, and then used those monies basically as kind of a mini health department, although there is a health department in Fort Collins or in Larimer County that they work with closely. So their challenge was, as a local taxing body, they had to provide services to improve the population of that health. Okay, let's go on to the next one. So when we did an assessment, helped them do that. Well, they have done assessments every 3 years since 1995. And this was looking at between 1995 and 1998, the first 2 assessments. And what they discovered was kind of disturbing, because they were spending a couple $1 million a year on population health improvement kinds of strategies and doing some really nice programming. They had mobile vans and all kinds of other stuff. But what they saw in just a 3-year period were fewer people describing their health status as excellent. So people's health status overall was getting poorer, and a variety of chronic diseases, vision, hearing problems, toothaches, migraines, diabetes, etc., were actually going up. There was more of them than there was in 1998 than there was in 1995. And they're freaking out. What are we doing wrong? Things are getting worse in this community. So we had a conversation with them about what might be happening in this environment. Go ahead and skip to the next because there were some other. Oh, I'm sorry, back up one. Yeah, there we go. So other things that they did that were kind of conflicting is that there were improvements in people not having a place of a regular preventative care. So more people had a place to get care, fewer people had no health insurance, and access to care was better. So these seem to be conflicting. Health status is getting worse, access is getting better. What's going on in this environment? So we asked them to step back and say, well, what's different between 1995 and 1998 in your community? They said, well, let's see. You know, we built a bunch of retirement homes. We got a bunch of older people that moved in the last 3 or 4 years. I said, well, do you suppose they brought their chronic disease with them? And they kind of looked at me like, what? And I said, yeah, think about it. You've imported a bunch of people. They're fairly wealthy because these are really nice condos. You know, they look up at Estes Park. It's a beautiful environment. But what is it about the change in this population? They're older people. They have more chronic disease. They have better access to care. They have health insurance. And so it's not surprising these things seem to conflict. There's nothing you're doing poorly, but maybe you need to take a step back and look at what are you doing for the older population, given that Fort Collins is the home of Colorado State and it's a very youth-oriented community. So anyway, that's an example of how an assessment can come up with some really interesting information that you wouldn't find otherwise. So we're going to skip on then to the questions and answers and make sure we've got plenty of time because there may be some questions about the presentation since it was kind of fast and kind of disjointed, and I apologize for that. But you may also have, okay, well, let's before we go there, let me just run through this kind of challenges and tricks of the trade. Survey costs keep going up. Cell phones complicate things. Those are really big challenges to deal with. The last survey I just did a couple of months ago, we only did 800 household surveys because that's all this community could afford. It was still very valuable, but in the past I would have recommended, well, if you're going to do this kind of survey, spend that kind of money, survey a couple thousand people. The prices have gone up such that that's just becoming impossible for many people to do. Again, community discussion groups is a much more cost-effective strategy than focus groups. And perhaps the most important trick of the trade, I would argue, is that the amount of secondary data that's now available compared with 5 or 10 or, gosh, 30 years ago when I started doing this, we had to buy census data on reel-to-reel tapes from the Census Bureau, then take it to a university that had a tape reader to get the data off of it. I mean, it's not something you can click on a website. You could have clicked on it. We didn't have websites, right? Okay, I'm really old. Anyway, so now on to questions and answers. So I guess that means you unmute them and let them, oh, I forgot that too. Yeah, let's go ahead on.
Okay, perfect. Let me get the chat feature up. So if you have questions at this time, you can go ahead and type them into the chat box. I will also, if you raise your hand and you want to speak, I would be happy to unmute you. We don't usually unmute everyone just because of a lot of background noise and this is the lunch hour, but I might be able to go ahead and do that if we don't have too much feedback. So we will just give you a second. If you have questions, go ahead and type them into the chat box. If you want to type a question anonymously, you can direct it directly to me, Cassidy Avila, and I would be happy to read it anonymously for you. We'll just give you a couple of minutes. We will have the slides and the recording of this presentation available to you. You should have it by the end of the week. We will also post it to our website, and you can access it there as well. Let's see, we don't have any questions yet. So let me prompt you guys with a couple of questions. So has anyone conducted a recent health assessment and you want to talk about your findings or something maybe that surprised you that didn't match up to your perceptions of what you thought would be your top challenges or issues in the community? Does anyone want to speak to that?
Did I scare them all away?
Maybe. Well, we still have them. We still have quite a few people on the line. So I'm going to go ahead and unmute you. You can keep yourself muted if you wish. This way you can just, we're getting a lot of feedback. So maybe we'll keep everyone muted.
Well, let me go through this one slide that you have up there, and maybe that'll prompt some people thinking, but they should be encouraged to interrupt if they want.
Yes.
So there's lots of uses for community health status data besides simply turning in your 990 form and putting it on your website. Not that anybody would do just that. But when you think about the community I live in, for example, the Brazos Valley here in Central Texas, we have documented about $20 million in grant funding that have come in the last 15 years to this community specifically because of the community assessments we've helped conduct locally and the availability of having that data for United Way, local hospitals, other organizations to be able to do grant writing. And so we've made the data available to anybody that wants to use it. It's not a condition that we at the university have to be somehow written into their grant. Well, it's nice when it happens, but basically it's a resource that can be really useful. Obviously, community benefits documentation, different kinds of accreditation, HEDIS, et cetera, can use the information from your assessment. Some communities and some institutions that are affiliated with medical schools, nursing schools, et cetera, will even use this kind of data for part of their health professional education training or continuing education activities. I've had hospitals use community assessment data for physician recruiting. I've had physicians use this kind of data to decide where they wanted to locate a practice. Certainly, there are contract negotiation opportunities for setting reimbursement rates based on population health status that you can use that this data can drive. I'm thinking about capitation in particular. Things like estimating pooled risk. If you want to know how many Jim Burdines are out there that are about to have their next heart attack, that's really valuable information before you go into a contracting situation. And certainly for strategic and market planning or program and service planning purposes or evaluating those programs, having this kind of baseline data and then being able to make comparisons like the folks in Fort Collins that I mentioned really can drive your decision-making in a much more informed sort of way. Anybody pop up with anything yet?
We don't have anything yet.
Okay.
And like I said, if you don't want to type your question, just let us know in the chat to unmute you, and we would be happy to do that.
So a couple of things I'll tell you about from my consulting days. When you're hiring a consultant to do this kind of work, I would ask questions not only about their formal training, but their practical experience, because as I said, you look at any two communities and you're going to come up with very different sort of prescriptions for how you might go about doing an assessment in one place versus another, even though they may demographically or institutionally look fairly similar. There are huge differences that only experience teaches you. It's not a matter of having a degree in public health or health services research or psychology or whatever. That's the deciding factor in whether somebody knows what they're doing. Do they have a sense of community? Do they have a sense of how places work? And what are the kinds of questions they ask you? What do they want to know about the community when they're interviewing you as a potential client while you're interviewing them as a potential consultant?
Has anyone conducted a household survey? Does anyone want to share that information? Just give us an idea. Or has anyone conducted a community discussion group? I'm not seeing any responses. Okay, well, they're eating lunch. So if you do have questions, please feel free to email us. We will get back to you with your questions. And like I mentioned, we will have a recording of this webinar as well as the slides available to you, hopefully by the end of the week. I do want to plug our website now, optimizingruralhealth.org. You can access this webinar there, as well as registration for upcoming webinars. In July, we've had this Community Needs Health Assessment webinar in July. In August, we will have a patient safety webinar. And then in September, we've got kind of a unique Q&A webinar or panel forum, I suppose. We will have someone talk about rural hospital finance, marketing, and then we will have Angie Alanis available to ask questions, for you to ask questions about community engagement. So that should be an interesting time. Have your questions ready. We'll devote the whole hour to getting those questions answered for you. So you can check out registration for those upcoming events on optimizingruralhealth.org. We will also open up our application in September. We will open up the application for our next round of technical assistance for rural hospitals for Tier 1 and Tier 2 levels. So if you want more information on that, optimizingruralhealth.org, or send us an email and we'd be happy to get some more information out to you. So I'm going to check the chat log one more time for questions, and if we don't have anything, and Dr. Burdine doesn't have anything, okay, he's good. So we thank you so much. We apologize for the technical difficulties, and I apologize for you having to rush through that, but we appreciate you doing it, and we will see you all next month. Thank you. Bye-bye.